I'm David Gertz, and I'm the Brandman Foundation Professor of Cardiac and Pulmonary Diseases of the Hebrew University Faculty of Medicine in Jerusalem. My presentation today at the 2017 Annual Scientific Sessions of the International Academy of Cardiology here in Vancouver was entitled Thromboembolic Complications of Abdominal Aortic Aneurysm, Pathogenetic Mechanisms and Lessons from PRINZMETALS Angina. The message of my talk was essentially that the pathogenetic relationship between abdominal aortic aneurysm and associated intraluminal thrombus is actually quite different from what has been intuitively expected. We pointed out that although the intraluminal thrombus is found in up to 70 to 80% of patients with abdominal aortic aneurysm, critical obstruction of the aorta by thrombus or even distal occlusion following embolization are very rare. Another common misconception is that intraluminal thrombus occurs primarily because of pooling or stagnation of blood in the areas of aortic outpouching. The truth is that the underlying morphological substrates on which intraluminal thrombus develops and from which aneurysms appear to progress are actually sites where the overall rate of blood flow is not only not reduced, but is actually associated with wide damaging variations in hemodynamic wall shear. Another critical point is that thrombus is not just a homogeneous inert mass whose danger is dependent on the degree to which it occludes the lumen. The truth is it hardly ever occludes the lumen, and in the aorta, the threat posed by thrombus is due primarily to its high biological activity, including inflammatory cell infiltrates, upregulation of proteolytic enzymes that facilitate wall degeneration, aneurysmal dilation, and eventual rupture. We showed from studies in our laboratory as well as others that the initial morphological substrate on which aneurysms appear to develop and progress and on which the intraluminal thrombus appears to form are actually sites that have hemodynamic properties common to many sites of altered vascular geometry, including arterial curvatures, branch points, partial arterial constrictions, such as can occur in, for example, cerebral vessels after subarachnoid hemorrhage or in coronary arteries in association with PRINZMETALS angina. We showed how endothelial damage at these sites of altered hemodynamic stress is followed by platelet attachment to the exposed subendothelial tissues that initiates the thrombotic process that further damages the arterial wall due to its due to the high inflammatory and proteolytic activity of the attaching thrombus. And finally, from these studies, we see that apart from risk factor modification and close advanced non-invasive monitoring of progression, effective prevention of aneurysm progression must address the underlying cellular and molecular mechanisms of vascular injury. And contrary to what some might think, it might also include much more widespread but certainly judicious use of antiplatelet therapy and possibly even antithrombotic therapy, but certainly after appropriate hematological evaluation.